All right, so Harry, obviously a big part of our company is our founding story. So you coached me through chemotherapy and radiation for my non-Hodgkin lymphoma. One of the things that interests people most is that you had the same cancer than I did 3 years prior. If you just tell us how you had a symptom, how you got it diagnosed, and then what happened.
So I'd been working as a hospital resident at the time, and I had a lump pop up in my neck, and I didn't think much of it. Just thought it was a lymph node fighting off an infection. But it actually grew reasonably large, like a grape size, and it didn't go away. I thought it was probably related to Crohn's disease, which I'd been suffering since I was 18. So I naturally, being a doctor, self-medicated, took some prednisolone, and sure enough, the lymph node went down. I stopped taking the prednisolone, and the lymph node reappeared. But I thought, well, if it goes down with prednisolone, it's going to be a reactive lymph node, nothing to worry about. The reason I ultimately had the lymph node taken out is because I had a run of night shift coming up, and I desperately didn't want to do this run of nights. So I went and saw a plastic surgeon who agreed to take out the lymph node so that I could get out of my night shift duties. He took the lymph node out, and when I saw him post-operatively, he said, yep, it came out, slipped right out, wasn't adhered to anything, nothing to worry about. But then the next day or the day after, it was early in the morning, I distinctly remember it, I was in my apartment about to go to work, and I got a phone call from the plastic surgeon, and he said, I've got some bad news for you. And I just remember this feeling of being just slammed with it's like a mental sledgehammer, just been hit over the back of the head. Just those words, I've got bad news for you. But all I heard was cancer. And he said to me, you've got what looks like aggressive non-Hodgkin's lymphoma, a B-cell lymphoma. And I've organised for you to see the head of haematology at Peter MacCallum, which is the local cancer hospital in Victoria. So 24 hours of whirlwind testing, saw a bunch of doctors, oncologist, haematologist, radiologist, had my heart checked, bloods checked, bone marrow biopsy, PET scan, all within a day and a half. So it was horrendous. And I just remember thinking, I was 35 at the time. I don't want to die at 35.
Yeah, I was around the same age.
The specialists couldn't agree on the diagnosis, so they knew it was non-Hodgkin's. This lymph node got passed from pathology clinic to pathology clinic. It actually made its way around back to Peter MacCallum, over to a specialist in Adelaide that was the lymphoma guru, because it just wasn't a typical lymphoma. Now, I think if it was, reflecting now, I'd had treatment for Crohn's disease, which involves immune suppression for the best part of 15 years, right? And if that was, it was very likely that was contributing, but I was treated anyway with radiotherapy and I worked through it as well, worked right through it. I never felt sick at any point. I just had a lump in my neck, had it taken out, was told I had an aggressive lymphoma, and then was treated and carried on.
Yeah, and so we met after that, and I remember you telling me that story, and I was like, oh, shit, cancer, you don't want that. And then we were working together with Specsavers on the board, having a great time, revolutionising eye health in Australia. It was incredible. And then I just had a sore back. I never felt sick either. And then you told me to get an MRI. So the fact of not being sick, not feeling sick, was something that we both shared, because there was no other, for me, there was no other symptom other than sore back. It's funny when you look at it and say now, we're, fast forward, we wrote this business plan during my chemo to say, how do we look at natural health? And really inflammation was where we zeroed in on, because that's everywhere and it's mistreated a lot. So tell us, obviously you're prescribing GP, your focus now in medicine is on longevity and making us stronger for longer. But what are the common problems people are having now? And is it ibuprofen overuse? Is it a misunderstanding of inflammation? What are the issues?
Yeah, I think what we're coming to understand is that inflammation underlies so much of chronic disease, and it's chronic disease that foreshortens our lives. And it's not only shortening our lives, but it's shortening our good years. So in Australia, and probably here in the UK as well, life expectancy for a woman is probably 84 years, and life expectancy for a man's 81. But the last 10 years of that are often infirmed, dealing with chronic disease, whether it's neurodegeneration or metabolic disease or cancer, cardiovascular disease and stroke. These things lead to many people having lives not worth living after the mid-70s. And it's inflammation that underlies so many of these conditions.
And so then the elderly or in that they have issues with non-steroidal anti-inflammatories or NSAIDs or ibuprofen.
They're fantastic drugs for short-term use, but that's the problem, is that people tend to reach for them all the time. And we know that a really significant proportion of presentations to medicine are due to overuse of these drugs. Because they're so effective and because they're so accessible, people use them, and then we get the consequences down the track, which are things like stomach problems, stomach ulcers, kidney problems, bleeding disorders, increased risk of cardiovascular disease. So a natural alternative is just gold. To be able to take something that isn't pinpoint knocking out a really important enzyme and effectively helping pain, but is able to treat inflammation in a much more broad sense. So curcumin, naturally occurring, is something that we can take every day without worrying about our stomach and our kidneys and our clotting and all that sort of stuff. So I think when you think about how inflammation underlies all of the chronic diseases pretty much, and we haven't had a good solution. There's a real opportunity for Kurk.
So tell me, obviously we've formed this science advisory board. Just a summary of each person with one line and what different backgrounds from Ross and Quentin and David. What are their backgrounds simply, and what's the objective of our science advisory board?
It's really to put some meat on the bones of our understanding behind how curcumin works, our particular formulation of curcumin, which is Kurk. We want to know things like bioavailability, safety, efficacy, dose response. What's the best way to take it? We want to assemble a panel of experts that have all got a different background. My background is I'm a physiologist by scientific training and a medical practitioner, but we've also got David, who's also a medical practitioner, and his expertise in sports performance. So he's interested in recovery and athletic performance. So we've got Ross, who's a clinical immunologist, so with a background in looking at viral illness, lung conditions, things like echinacea, the role of those naturally occurring bioactives. And then we've got Quentin. Quentin's background is in infectious disease. So he looked at malaria, and he also became quite a prominent speaker on COVID when that first hit.
Okay, so in terms of your current medical practice now, My Performance, one of the biggest things there is understanding the difference between health span and lifespan. So explain what that is.
Yeah, I think it's easy to understand lifespan. So lifespan is just how long we live. But as I said before, there's a part of many people's lives where you're not healthy. The last 10 years perhaps is in and out of medical institutions, hospitals, nursing homes, and so forth. So relatively infirmed. And that's common in the Western world, where we tend to live a life with a slow decline. And the slow decline is due to chronic illness. So Healthspan is about pushing that period back further, so the time at which we start to become infirmed later in life. If we can detect disease early or the signs of it early and maybe stave off chronic disease, then we get to live a life worth living for a longer period of time. But if you could live a really healthy, vibrant, vital 82 years and then die at 83 years, that's a better outcome than living till 84 years but spending the last 10 years in and out of a hospital.
Yeah. So look, I think every person, we've all got relatives, and we all look at some relatives that age better than others, and we always wonder why. Is it genetics? Is it lifestyle? Is it better treatment? What are the main differences, the people that have a better health span as opposed to lifespan?
I think luck is a big part. I'd be lying if I said it was something other than luck at the core. You don't get to choose your genetics. You don't get to choose where in the world you were born or raised. So that's a big part. And then it's choices about nutrition, about sleep, access to medication, quality food. Low levels of stress will elongate your life. So people that are chronically under stress, far more likely to get chronic disease. Yeah, so it is multifactorial. There are people that have smoked their whole lives and lived to 100. And then there are 18-year-olds that die of malignant metastatic melanoma that was undetected until it showed up everywhere.
So the rise in longevity science and the experts in the field, Peter Attia, Andrew Huberman, David Sinclair, all these pioneers. So you're in that field now. Obviously, you're here in London to talk at Atom Conference, a very select group of people looking into the future of healthcare. What's a simple thing for people to be able to do to improve their lives or improve their health span?
I think the most important thing that anyone can do to increase their chance of living a long and healthy life is to determine whether they have something going on today. So that is to start looking for the early signs of chronic disease, whether they are inflammation or other blood markers. Imaging is really useful in detecting early signs of disease, whether it's cardiovascular disease risk, stroke risk, metabolic disease. These things are able to be picked up early. Unfortunately, the healthcare system isn't really geared up to be proactively looking for these things. So it is up to people to either find a doctor that has an interest and the time and the will to work against the tide and promote proactive screening for people. I think training, physical activity, and one of its major correlates, which is body composition. So it's our physical body that has to get us through to old bones. So that means we need enough bone, we need enough muscle, we need enough strength, we need enough flexibility, we need enough mobility to make it through to be a robust 80, 90-year-old.
Okay, so the latest science now regarding longevity is about you want to increase muscle mass. And one of the biggest indicators of a healthy aging process is grip strength. This was fascinating to me. Can you explain that?
So grip strength is correlated with longevity, with lifespan. But it's really just it's a marker of muscle mass and muscle strength. I think if you specifically trained grip strength itself, like set a program to increase your grip strength, you're not going to live longer. It's a marker that represents you overall in terms of your neuromuscular and muscular strength and skeletal muscle and skeletal mass. So people need to be careful with this.
Yeah, so it's not just a hand grip.
Correct. If you go and work on your hand grip, okay, that's lovely because you will be able to carry the shopping, right, up the hill at the end, when you're 80. But that's not what to work on. It's just a correlate of things like physical training and your body composition.
Right. I'm going to ask a quick response from you about different people in the decade that they live in and what are some simple things. So 40 to 50, 50 to 60, 60 to 70, 70 to 80. So if you're in the age bracket of 40 to 50, what are the quick things you should be thinking about to make sure you're going to be good at 70 and 80?
40 to 50, first rule out disease and deal with the early signs of chronic disease, inflammation, etc. That's the first thing. Get screening, so blood testing can pick up early signs of metabolic disease, cardiovascular disease risk, even risk of neurodegeneration. So there's genetic testing that's easily available, it's cheap.
So that's what Alzheimer's, dementia.
Yeah, ApoE genotype. And then in that same decade, training, physical training, body composition. So having a body composition measurement, a DEXA scan or a bioimpedance scan if you can't get a DEXA scan, and that's your starting point, and then working to improve that to push up into the top quartile.
Yep. So someone that's now 50 to 60, what should they be looking at?
Sniper alley for a man. You're in sniper alley. So this is a very, very important time for men in particular. So this is when prostate cancer can appear, cardiovascular disease can appear, metabolic disease appears, cancer appears. So particularly men in this bracket, but women as well. So I have, with proactive screening, detected breast cancer, prostate cancer, advanced cardiovascular disease.
So you're getting that before they've had the symptom, which what's the difference in our health outcome or treatment?
It's enormous because it's early intervention. So no matter what the disease, but especially cancer, stage 1, very likely that person lives. Stage 4, it's much harder to say that.
So 50 to 60, it should be a red zone for men to go and
particularly
get
men,
checked
but women as well, of course. So breast cancer in that decade for women, and also other gynecological cancers in that decade. So really important to be screened.
And then 60 to 70 years old, what should they be?
It's the same suspects. It's metabolic disease, cardiovascular disease, stroke risk, cancer, neurodegeneration. And the treatments are the same. So we have medicine at our disposal, supplements at our disposal. So things like Kurk for inflammation, but also it's the basic stuff. It's sleep, it's nutrition, it's training. Right? It's making sure your blood pressure is in the normal range. This is why I have all my patients monitored with blood pressure cuffs, body composition scales, something to monitor their sleep stages, whether it's an Oura Ring or a Whoop or an 8 Sleep or one of those gadgets. Really important. I measure my patient's VO2 max. Just an estimate is fine. Oura Ring, Apple Watch, Garmin Watch. There's a number of different affordable gadgets that people can get a read on their health, for cheap.
It's funny because, obviously us suffering the cancer scare focuses us on our health, and we've devoted our whole lives to that now. Most people don't, fortunately, because you don't want that. But then most people say health is wealth. Oh, you got nothing without your health. And then they move to their next thought and they don't do anything about it.
I think it's somewhat our fault, and in some ways not our fault as well. I think as a doctor, I was trained in a scarcity environment. We're not proactive. We're treating sick people. And health funding is overwhelmingly diverted towards treating illness. It's not about prevention. That's made doctors less than expert in prevention, and it's taking medicine a while to come around to early treatment. So, for instance, a recent study on cardiovascular disease showed that low-dose colchicine, which is anti-inflammatory, is effective in reducing cardiovascular events. I think also as citizens, we've been in a position where we've just been taught to wait until we're sick to go see someone. And if you presented to medicine in an early stage, you'd be sent away because medicine's not good at picking things up early. now I think we know a lot more about the early signs. Even if you don't have a blood test or a scan or whatever, if you've got inflammation, you're at increased risk of basically everything. Cancer, metabolic disease, cardiovascular disease and stroke, and neurodegeneration, the biggest causes of death and disability.
And so we've studied inflammation at a very deep level in our lab in Twickenham. So inflammation is also healthy in a way, right? So when does inflammation become a problem? Is it the immune system just misfunctioning? How does that work?
Yeah, I think it's the simplest way to explain it is we need inflammation. It's a really important part of dealing with injury or insult, infection, some sort of damage to our physical body. Inflammation is the body's way of summing all the cells and molecules that are going to help us defend and then heal. So it's important. But when it's dysregulated, when it's over the top, when the response is disproportionate to the insult, that's when we get into trouble. So there's various forms of inflammatory illness. Some are autoimmune, so where our own immune system is attacking us, our own body, maybe because it's confused part of our body with a viral antigen or something it's got a memory for. And then other times, in the case of cardiovascular disease, what you have is LDL cholesterol particles entering into the wall of an artery, and then that sets off an inflammatory reaction, which is harmful in the end. If that artery wall bursts, then you get platelets jumping on, you get a clot forming, and that blocks the circulation to the heart itself, causing heart attack. And likewise, if it's the circulation to the brain, that's a stroke. So they're inflammatory.
So then with Kurk, we're targeting the dysregulated, the inflammation that doesn't serve a purpose. How does it work?
Yeah, I mean, it's a fascinating molecule, curcumin, because it's working at the level of the epigenome. We all have our genome, that's our genetics, but epigenetics is really about which genes are switched on and which genes are switched off. And curcumin is thought to act, or does act, among many different pathways in the inflammatory cascade. Inflammation is not just one pathway, it's multiple pathways leading to multiple cell types and other parts of the immune system dealing with insult, injury, infection. But curcumin works to dampen the epigenetics of inflammation, basically dial it down. That's the simplest explanation.
Yeah. We get a lot of patients who have osteoarthritis. I've got it already from jiu-jitsu and rugby and all of this. And when we do studies on ourselves, I've got to wash out. I feel the build up in the fingers. I feel it in the neck. I struggle when I train. I'm not that motivated because everything's a bit stiff and sore. Then when I go into our protocol and I might do double doses or large doses, usually within a day I feel it. But then it's got this progressive there. I take it every day. I forget I have those injuries until I stop taking it again. I know this is common with our patients. What causes that?
Yeah, it's, again, really fascinating. This is what we're trying to determine with the Scientific Advisory Board. We know that the appearance of curcumin in the blood is quite transient. You know, it may be there for 4 hours, but its effect on the epigenome is long-lasting. It's not like taking ibuprofen. People shouldn't expect to feel pain relief in the same way as if you took a painkiller. The most common report that we get is people notice when they stop taking it. So if you've taken it for a few weeks consistently, then you've probably forgotten about your sacroiliitis or your sore knee or your sore elbow or your brain fog or something, because we're so good at forgetting. I know I am. I just forget that symptom. But if you stop taking it, like when I travel or something like that, then you notice. And that's a really common story.
Wow, excellent. Okay, so then my performance doctor, your main focus is on longevity. And I want to thank you because that's our pact. We had a pact when I was going through chemo, a very tough time in my life, when we made our 100 pact. We're both going to live to be 100 years old. We've had a series of discussions on this. How can we do it? You're studying it as a physician and a researcher, and I'm trying to understand it and look at products and supplements and what I can do to help me and my family. The 100 pack's a really interesting thing. Are we getting closer in terms of probability of making it to 100?
I think so. I think you can't guarantee it, obviously. And again, I think luck plays a huge part. But if you know the things that can sneak up and bite you, things like chronic disease and inflammation underlying most of those, and you intervene early and you increase your chances of forestalling chronic disease with nutrition, sleep, training, etc., then we are increasing our chance of making it through to 100. So I've got another 46.1 years to go to get to 100.
And I've got 52, so you're going to get there first. So then the pressure's going to be on me in those couple of years.
Well,
You're
that's
just
right.
going to have to pull me through. But obviously we're going to have strong health span. So I'm expecting we'll have your 100th in Ibiza.
Yeah, I think that's right. It was either that or Miami. But, yep, Ibiza's probably the choice.
Excellent, excellent. Okay, so in terms of my performance doctor, what have you learnt yourself in the last 12 months? What has changed your mind, or what has been a surprise for you medically, academically, scientifically?
I knew this already, but people are different. Everyone's different. They all come with their own preconceived ideas, their own problems, their own way of looking at things. So I've had a reminder of that. So I obviously have a small practice specialising in preventative medicine and longevity. People take up my service in different ways. They've got different priorities. Some people, go and get all the testing done, do it by the book, wear the continuous glucose monitor, check their blood pressure every week, try and get 8 hours sleep, that sort of stuff. And others I'll just have a blood test every year or so. I'll let you know when I need you. I'll be fine. And that's okay. So I think coming to accept that people are different in their focus, their priorities and so forth. Scientifically, I think we're in a really interesting time now because, what we're seeing is that there are drugs that have been repurposed for longevity. I think 9 of the top 12 are repurposed diabetes drugs. So we're starting to understand at a much broader level and a deeper level the role of, nutrient sensing and the opposite of that, fasting, on longevity. So fasting, we've both tried it. We've done intermittent fasting or time-restricted feeding. We've done long fasts, multiple day fasts. They're really annoying and unpleasant. And I don't like doing it because I like eating. But there are drugs that are mimicking that impact. So when the body fasts, it goes into a recycling phase and it stops its growth phase and it starts to recycle cellular detritus and fragments of DNA, which go on to cause chronic disease, inflammation, cancer, and so forth.
It's autophagy.
Yeah, autophagy.
So these are the semaglutides, GLP-1s.
Well, so that's it. They're a bit different, but it is similar in that it's lowering insulin. So our exposure to insulin with these drugs, like metformin, like the GLP-1 agonists, our exposure to insulin is reduced. Insulin is highly inflammatory. So again,
but we need it, right?
We need it, but we don't need it all the time. We need it when we've got to put nutrient away, and then you want it gone, right? Be brief and be gone. But with the Western diet, there's a lot of insulin around, and all of the metabolic consequences of that.
So this is bad food eating, sugar, all this stuff, spikes your insulin, leads to obesity,
Inflammation,
leads to
metabolic
diabetes.
disease, cancer, everything. The risk of all those things goes up with increased fat.
So what's worse, smoking or being obese? Both, and are they both the worst two choices?
Yeah, they're the worst two.
Of human nature, they're the worst two choices we make to either start smoking and can't stop smoking or eat the wrong foods.
I struggle more with smoking just because I can't relate. I don't like the smell, and it's never been something I've personally had to deal with. But I understand liking chocolate, right? And apple pie and ice cream and whatever, Fruit Loops. I understand that. That's hard. We're geared to eat. Our genetics are geared. Our behavior is geared to eat. There's nothing at all worse for us than your body sensing diminishing reserves of energy. So when you're losing fat, everything in your body is saying, stop losing fat. Eat. Hunger is the most, it's the behind oxygen, oxygen and pain. Hunger is third. It's above sex. It's above sleep. It's above everything else. Your desire for all those things. Hunger's number 3. And when you're hungry, you can't think. You just simply cannot think. So it's very potent. So I get it. If you have a choice, though, of being obese or not, you probably won't choose not.
You've been a man of science all your life. 5 degrees in medicine and science, practicing doctor, professor, now longevity expert, got a bioscience company where we're looking at natural compounds. What have you changed your mind on scientifically or academically in whatever time period you'd like to share?
I think the advent of GLP-1 agonists has probably been the biggest change in my thinking in recent memory. I think before they came on in, let's say, 2016, I think I started taking them myself in 2017 for metabolic, not for weight loss, but back then I just wanted to lower insulin for metabolic reasons.
That was for cycling to
just for general health, but of course wanted to be lean and fast and all those things. I think we can afford to, it's a superpower, this drug, because we can afford to not be so dogmatic about what we eat. Before that, it was keto. We knew less carbohydrate was a good idea. We knew calorie restriction was a good idea. We already knew this stuff. It's just very hard to execute. Now with GLP-1 agonists, it's a superpower. People can choose. You can have a slice of pizza and go, I'm good. I could never do that before.
Okay, so I understand about ghrelin and leptin. One makes you hungry. Ghrelin, it's the hormone that I better eat.
Yeah.
Leptin's when you're full.
Well, leptin is they're both signaling molecules, right? But leptin is the body's way of gauging energy reserves. So when we have high fat levels, we have high leptin levels, and it's the drop in leptin that actually triggers hunger. So that's what we're working against when you lose weight. As I said, with the advent of GLP-1 agonists, that's not so much a problem because you've got central suppression you've also got delayed gastric emptying, so you feel full. So all the signals to your brain are, you don't need to eat now. And then you can be choosier about what you eat. And people find, quite magically that they make good food choices on a GLP-1 agonist.
So to reduce the size of your stomach, so you feel full and you don't eat as much to lose weight, right? So are these GLP-1s the drug alternative to that?
Sure, absolutely.
And it's better than having a surgery?
Because the surgery was the best we had, and it was shown, level 1 evidence to reduce death and disease in people with diabetes. But it's nothing like a GLP-1 agonist once a week injection, and then you lose 10, 20% of your body weight, within a year, and it's magical.
And what's the downsides? Protein, muscle?
Yeah, you lose everything.
So it's not just brown fat?
No, you lose bone, you lose muscle, you lose water, you lose fat.
So there's a cost, hence, by getting it monitored correctly.
No, I think that's really important. Even if it's just a home body composition scale, it's better than nothing. But people need to keep their protein up. As you said before, sarcopenia or muscle shortage is a cause of frailty, and not making longevity an option if you're weak. I mean, you look at people in the street, right? You can tell who looks frail, and they're just not going to live much longer.
Yeah, it's visual. So obviously being a scientist and a medical researcher and a GP and now longevity, what's the most common question you get asked at parties when people realize what you do?
If it's a guy, it's almost certainly, should I take testosterone?
Right. That's a over 40s guy or a roid rager, big muscle builder.
No, I mean, it's usually guys who are starting to feel not quite as strong and robust, and they may have had a friend start testosterone.
So it's a hormone supplementation.
It's a hormone, it declines with age, and it's a really important hormone, both for men and women, mostly for men though. Unfortunately, the medical profession not great at this, so guys go underground. They see their gym bro friends and get stuff sent from Thailand and Germany and India and what have you, and who knows what they're injecting. I mean, it must have a bit of testosterone, I presume. But that's probably the number one at parties, and I don't know. I guess nowadays it's of course talking about Ozempic and Mounjaro,
GLP-1s.
Yeah.
That's made it into the mainstream. Everyone's wanting to know about it.
Yeah, I think so.
Okay, so what is the question that most people should be asking you, but they don't?
Well, I'd like to think it's what's the most important thing I can do for my health? Or alternatively, how do I deal with this piece of information? How do I deal, because it's coming at us like drinking from a fire hose. Honestly, it's, even for me, with my background and access to all the journals and UpToDate.com and ChatGPT and Perplexity, even I find it a struggle. So you need a framework to cope with this. Where does this fit in to, the grand scheme of what's important in health and what isn't? While things like sauna, cold plunge, hyperbaric chambers, and breathing, are really important, they're at the tip for me. And don't get me wrong, I've got a sauna in my backyard and my bedroom is an altitude chamber. So I'm a believer. But the most important thing is, have I got something going on today that I could remedy?
So
have I got cardiovascular disease? Have I got inflammatory illness? Have I got early signs of metabolic dysfunction? Have I got any of these things? Have I got cancer?
So let's not get fancy with all this. See if there's a ticking time bomb.
Right. Let's see if you're okay. Now, if you're okay, let's talk about training. Let's make you stronger. Let's make you fitter. Let's make you more flexible. And then let's get all the other stuff that's really important. We all know it's not rocket science. It's really basic. It's just sleep, eat, train. Basic stuff. And then you can get fancy. Then there's molecules out there that are really interesting. But they're not the silver bullet.
So if you go the Pareto principle, the 80-20.
80-20.
Go and get whatever test you can.
Whatever you can.
Wherever you can get it.
Yep.
And try to pre-screen for the big four.
Yeah, I think, look, home. There's a lot to be said for home testing. The Hawthorne effect, the very act of looking changes the outcome. Measure your sleep. Measure your body weight, body composition. Get a continuous glucose monitor for a month. See
you
what
understand what foods do what with.
It's crazy. Advising athletes doing point-to-point races, 7-hour races.
These are cyclists.
Yeah, cyclists. National champion level cyclists. Elite cyclists. World Tour pros. And I was giving them nutrition plans for races. And when I look back now, knowing what I know from continuous glucose monitoring, I knew nothing. when I learnt the effect of white rice on blood sugar, that's all I needed to know. I had a bowl of fried rice from the sushi shop round the corner. It put my blood sugar at 10 within 30 minutes. I thought, I'm onto something here. I can do a 4-hour race on this. So it's just fascinating stuff. You can get a 1-month trial of a continuous glucose monitor, and you'll learn more about your metabolism in a month than you would have in your life up to that point in time, including the effect of a chocolate bar or a fruit yogurt.
And so that by that measurement or understanding that with the Hawthorne effect, then the motivation of it will probably be less because you go, I really like that, but man, I can't afford a 10 right now. I'm not about to do a race.
Bingo. That's what happens and look, we don't always have willpower to spare. That's I guess the other part of being a doctor. That's, I'm not dogmatic. I'm not prescriptive to my patients. I want to help them the way they want to live. You've got to give people a break, and you've got to give people the chance to go easy on themselves too. So a lot of my time I'm telling my patients, don't be so hard on yourself. It's hard. You're wired, we're wired this way.
What, to want sweet foods, to
Right.
sit on the sofa
Right.
and do nothing.
Exactly. So just stop being so hard on yourself.
And then we all know alcohol's bad, but then there's a social function of that.
Exactly right. So it's a balance, I guess. It's a balance. And yeah, I just think it's not realistic to prescribe abstinence of this and that, whether it's drugs, alcohol, short sleep and that sort of thing. It's not practical. No one wants it. So if I'm to be an effective practitioner, I've got to understand that.
I love Stoicism. And, when we look at the various schools of thought, one thing I've been fascinated is the things that stand the test of time.
Mm-hmm.
I love chess. I'm not very good, but I play it regularly because it's lasted for so long. I love the Stoic stuff because it's lasted for so long. And the big thing with Stoicism that I like the most is a lot of the Stoics, they weren't up in the hills like a monk and just trying to get clarity by blocking everything out. They're down in the marketplace. They're working, very practical. So that's you. In my experience of you as a doctor, you are very practical.
Yes.
So okay, all right, it's a celebration, it's New Year's, or yeah, it's your big birthday, and yeah, you might have had, got your dose wrong on alcohol.
Yeah, that's right.
So yeah, too bad, suck it up. Then the next day, maybe let's try to train a little bit. Let's try to get some electrolytes in and all this stuff. So what are some common fixes or what do we do when we do overdose on food, caffeine, alcohol?
Yep.
Some people like party drugs, all these things.
Yep.
The goal is don't just throw it all away.
Exactly. That's the thing. For many people, right? And that's a real barrier for most people. Even myself, if I allow myself to think, what's the point of working out this week because I'm traveling on Wednesday? I'm not going to get to work out. It's not, well, I'm just going to lose all my gain anyway. And I think that's an important switch that needs to be flipped, is to go, you know what? I'll take that 20 minutes. I'll go and do some push-ups and pull-ups and bicep curls, jump on the trainer for 15 minutes because it's better than nothing. And I think just begin again is the approach people can and should take, and understand that bit by bit by bit by bit, they will find themselves 3, 4, 5 weeks down the track transformed without even noticing. All right, I'll get everything else wrong today, but I'll make sure I drink enough water. All right. I can't work out properly, but I'll do 20 minutes because that's all I can be bothered doing. Just turning up. As my cycling coach used to say, just put your socks on. Right. Once you got your socks on, you're okay.
Yeah, so my gym that I've started, we've got a mantra downstairs, and it's like 49 steps that might change your life. And then when you get to the top, it says, when it gets heavy, remember that you're strong. Exactly. All these little mantras that we have. And now, obviously, Harry, our 60-day challenge that we've got for a lot of customers, how to break bad habits or to move yourself forward, whether you want to start on the 1st of January and, New Year's resolution, the 60-day thing to try to either train a little bit harder or do something a little bit better. What are your thoughts on that? Just interventions and just various things.
First thing I'd suggest is don't. I don't know what you think about this. And we've got a funny story in that we used to set each other's New Year's resolutions. I think that's quite unique. I haven't heard anyone else set their mates' New Year's resolution. They were tough, but that's one way of doing it. But actually, I don't think we should have New Year's resolutions. You shouldn't wait till January 1 to start. You're wasting so much time. I know there's a mental reset, but for many people, there's not even necessarily a headspace break at that time of year. I know I'm just as busy that time of year as any other time of year, so there's no natural reason to wait till January 1. I think just begin now. So 60 days starting now. If you stumble and it takes you 5 days to get your first day done, so be it. My wife and I are completely aligned on this. I want to live now, make the changes now. Apart from our joking around with New Year's resolutions, I don't think it's a good idea.
Yeah, so it's just people push it all off and then just do a last binge and they last a couple of days.
It's terrible. I mean, look at gyms. You couldn't get a piece of equipment on January 3rd. And then by you rock up on February 15th, the place is empty again. We should just begin again. And then if you fail, just begin again.
Excellent. Okay, so look, you're a father of 4. You're a professor, you're a scientist, you're a doctor, you're a cyclist. Again, what's your tips for people wherever they are in life? What is your overarching philosophy?
I think, firstly, we need to be grateful. I found this very important in my life. If you don't utilize gratitude, you are bound to fail to be happy, I believe, because every other pathway leads to unhappiness as far as I'm concerned. So you've got to be grateful, number one. And even though I'm really a deep down a determinist and I'm a true believer in luck as the main driver, I think at a practical level we have to take control. We have to at least believe that we can change the outcome. So take control in whatever little step we can do. So I think that's one of the nicest things I've done to myself is stop trying to be perfect. Just try and do something. Try and do something every day. I remember at one point, I think I counted 50 things I was telling myself I should do each day. I've got to meditate. I've got to stretch. I've got to do my Pilates. I've got to do my pull-ups. I've got to talk to the kids. Have coffee with my wife. I've got to see my friends. I've got to call my business partner, etc., etc. You can't do it. You can't do it all. Just do something. Just do something. Now, I think when you do something, you feel in control, even if you're not.
Yeah.
Just the illusion of being in control is a wonderful feeling.
Momentum's on my side.
Momentum.
One in a row.
There you go.
So, Harry, you've flown all the way from Melbourne here to us in London. We've had a great time in our lab with the science advisory team. Obviously, Australia's really doing well for us in Kurk. Same with the UK. Now we've launched in the US, which is getting a phenomenal response. You're here to talk at a big longevity conference in Atom, and thanks for coming today and giving us your wisdom, but also the way you do it is a way that I understand. I think that what I've learned about medicine has come through you and it's stuck in my head, and I'm not really a scientist. So thanks for that today.
You're welcome. So I'm really grateful and always happy to get over to London. So thanks.